This is about 38 centimeters. This is important because as the tube is being inserted, in the could be the orogastric tube as it's being inserted and go towards the stomach. Of course, those measurements have to be put in mind because you can measure from the level of the upper teeth as you're inserting down. You know that from this level, 16 centimeters downwards, I'll find some bit of resistance because of this constriction. At the level of in the chest, about 23 centimeters from the upper teeth, I'll find another constriction. So if someone knows the levels of those corrosive substances can dislodge, causing injuries that can sometimes become cancerous. So those are very important constrictions. So as I was saying, as the nasogastric or orogastric tube is inserted, those constrictions have to be put in mind. Also, the endoscope. There is that wire that is connected with the camera to observe what is in the stomach. As all these are inserted, those constrictions are always put in mind to prevent challenges of injuring the wall of the esophagus. Okay. So these constrictions, you can somehow see them on imaging. Here you can appreciate one in the thoracic area, or the aortic or the bronchitic constriction. So at this point in the chest, this is your chest, and that is the natural constriction there. So don't say constriction and say that there is something blocking. You know the levels, you just know that that's normal constriction. The esophagus has 3 parts: part in the neck, part in the chest, part in the abdomen. And of course, all these parts are going to be, can talk about them briefly. So the cervical part, of course, will extend from the level of the cricoid cartilage to the level of the, as you can see it here, this is the cervical portion from the level of the cricoid cartilage to the level of the superior bone of the manubrium. Of course, we know we have the manubrium, although it's not shown here, as part of the sternum, and that manubrium, I estimate it's going to be around this point here, because we know that the first rib is going to attach on it. So you can see that this small piece here is the cervical portion of the esophagus. It's very short, and it is just running from the level of the cricoid to the level of the manubrium, superior bone of the manubrium. Of course, the relations in front of it, we have the trachea. Behind, we have the vertebral column. You can see the trachea there, vertebral column. Between the vertebral column and the esophagus, there are some tissues there, muscles, fascia. On the other side, you can see the lateral lobes of the thyroid gland. That's your gland. Has those lateral extensions going upwards. Those are lateral lobes. They are on the other side of the esophagus. You can even see it there. Then you have the common carotid arteries. These arteries are going to be ascending upwards. Of course, here we have the right common carotid on the left. They are ascending upwards on either side of the esophagus. In the chest, of course, we have the trachea in front. You can see it there still. Right pulmonary artery. That is the right pulmonary artery crossing the midline, just anterior to the esophagus. You have the left main bronchus, going to the left, crossing the esophagus. The left atrium is going to be situated in close proximity to your esophagus anteriorly, and that left atrium, we can't see it in these pictures, but we can see it in this picture. This is your heart. We have the left atrium there. It's going to be situated anterior to the esophagus. This is the esophagus. This is the esophagus. So we have the left atrium around there, situated in front of the esophagus. This is important because there's a condition that we are going to talk about later in relation to that. Then posteriorly, of course, vertebral column. Of course, we have the thoracic duct. You see it there in green. Sends upwards, crossing the midline to go to the left, passing behind the esophagus. The descending thoracic aorta, its lower extent, you see it running downwards. Initially, it's on the left side, but it's going to get close to the midline to become behind, or to be straightened behind, as you can see here, the esophagus. The right posterior intercostal arteries, where are they coming from? Remember, they are coming from your aorta, going to the right to supply the right chest wall, the right part of the chest wall. So they are going to be passing behind the esophagus, of course. On the right, you can see the pleura, the right lung pleura. Of course, on the lung itself, inside here, though it's not here. The esophagus, as it winds over the right main bronchus, the right vagus nerve. Okay, so all those are very important relations. On the left, of course, the left lung and pleura, we have the descending thoracic aorta. You see it in the upper portion. Thoracic duct, after crossing the midline, is going to run on its left side. Then we have the left subclavian artery. The left subclavian, you can see it there from the aortic arch, sending upwards on the left side of the thoracic part of the esophagus. So all those are structures in close proximity to the esophagus. I told you the left atrium is situated anterior to the esophagus. Here we are seeing the posterior view of the heart, okay? And of course we know we have the right atrium here, then the left atrium around that area receiving these veins. This left atrium is found in front of the esophagus. Also you can see the left atrium is there receiving these pulmonary veins. It's in front of the esophagus. It's in front of the esophagus. This is your chest, anterior, posterior, left atrium, in front of the esophagus. So sometimes if the mitral valve is, let's say, blocked or narrowed, blood is going to find challenges going through that valve. Blood is going to accumulate in the left atrium. This may cause enlargement of the left atrium. As it enlarges posteriorly, it's going to squeeze the esophagus, resulting into difficulties in swallowing because of the enlargement of the atrium. So this is called dysphagia megalantriensis, or you can call it cardiac dysphagia. There's difficulties in swallowing because of the cardiac issue. Which issue? Enlargement of the left atrium that could be caused by narrowing of the mitral valve. Okay, you can also see this is, of course, your heart bulging posteriorly, squeezing onto the esophagus. This is your esophagus. Can be clearly seen. There are some contrast agents that can be fed to a patient to allow clear visualization of this esophagus as this patient swallows these agents or this meal, barium meal. It's going to be coating on the esophagus so that you can easily see it on X-ray. So you can see it being narrowed because of the enlarging heart. So that is dysphagia megalantriensis. The abdominal part is very small, about 1 to 2 centimeters. It's going to be, of course, situated just posterior to the left lobe. Okay, and you can also see that the anterior vagal trunk is going to be anterior to it. And of course, this was the left vagus. But the left vagus, as it extends downwards, is going to come in front of the esophagus. That's why we call it the anterior vagal trunk. Then this one goes behind. That's why we call it the posterior vagal trunk. All in all these are coming to, of course, supply structures in the abdomen. Okay, so, of course, if you look at the wall of the esophagus, we have layers. Of course, as you know, your GIT has those normal layers, mucosa, we have the submucosa, muscle layer, and the adventitia, or serosa in some parts. Here it is adventitia because it's a very strong layer with fibrous tissue to connect the esophagus to the surrounding structures in the chest, to be well anchored in position. Muscle layer for peristalsis. Submucosa contains glands that can produce some secretions to lubricate the lining of the esophagus so that as food is going, as the bolus is going down, it doesn't cause irritations on the walls of the esophagus. The mucosa has, in most parts, stratified squamous epithelium, non-keratinized, for protection because the esophagus is prone to abrasion during swallowing. So all those are the layers of the esophagus, and they are all very important. In these images, you can appreciate more the muscle layer. You can see the sacral muscle fibers. You can see the longitudinal. Okay? And also you can see that there is that tissue, connective tissue, which is going to be connecting the esophagus to the surrounding structures, as I said, for firm anchorage within the chest. Then also, if you look around the inside aspect, of course, the mucosa, it's going to be stopping somewhere. And this area where it stops can be well visualized because the mucosa of the esophagus is not the same as the mucosa of the stomach. This is stratified type in most parts. This is simple columnar. So there's going to be some linear demarcation, some zigzag demarcation. This is a Z line. Is that line of, is that area where the mucosa of the esophagus coincides or meets the mucosa of the stomach. Okay. This Z line can shift upwards in some cases if there is if there is extensive reflux of contents from the stomach upwards. Those contents will shed this normal esophageal mucosa, and this mucosa will be replaced by the stomach mucosa that is resistant to the acids. Okay? And with time, this Z line is going to shift upwards because of the erosion of that esophageal mucosa. So those are the layers. Here you can further see the circular muscle fibers, longitudinal. They are going to be continuous downwards with those of the stomach. Of course, we know between the muscle fibers we have nerve fibers. We have the mesenteric plexus. Beneath the circular muscle fibers, or within the submucosa we have the submucosal plexus. All these help in stimulating these muscle fibers to contract so that we can have smooth peristalsis going on. The muscle fibers making up the esophagus can also vary to some extent. In the upper portion, we shall have the striated muscle fibers. Then down here, we shall have the smooth muscle fibers. Remember, down here we have the stomach, made up of smooth muscle fibers. Up here we have the pharynx. Part of it has got skeletal muscle fibers. So, of course, some of the skeletal muscle fibers of the pharynx are going to be, of course, similar to the muscle fibers of the esophagus in the upper part. That's why you see that this has striated muscle fibers similar to the fibers of the pharynx. The lower portion has smooth muscle fibers similar to the muscle fibers of the stomach. But they all have the same function, to allow peristalsis. They all have the same function. Of course, the nerve supply, we've just talked about it. We've talked about the plexuses of nerves that directly stimulates the muscle fibers. But these plexuses of nerves, they are under control of the autonomic nervous system. Autonomic nervous system is made up of parasympathetic and sympathetic. This allows digestion to take place. This prevents. So that means the parasympathetic fibers are going to be stimulating these plexuses to allow contraction, stimulating the glands in the submucosa to allow mucus secretion to lubricate the inner linings of the esophagus. That will be allowed by the parasympathetic. By these fibers, for them, they will do the opposite. Okay? So, the sympathetic, where do they come from? From the sympathetic chain. You see that chain there? It's alongside the vertebral column on either side. It's going to be, its role is to give off sympathetic fibers to different parts of the body. So it's going to give off sympathetic fibers to the esophagus. Fibers that will come and regulate the plexuses to inhibit them. Then the parasympathetic are going to be, of course, delivered by the vagi, the anterior, this anterior vagal trunk, okay, which was the left vagus. Then we have the posterior vagal trunk, the posterior vagal trunk on the posterior view, posterior vagal trunk, which was the right vagus. So these are going to be delivering parasympathetic fibers to the wall of the esophagus to come and stimulate this plexus and this plexus, allow smooth peristalsis and mucus secretion. So basically, that's how the esophagus is regulated. Of course, has to be supplied with blood, cervical part, supplied by the inferior thyroid artery. The inferior thyroid artery, it's this artery here. You can see it very well here. It's going to be coming off indirectly from the subclavian, giving off the esophageal branch to come and supply the cervical part. Then the thoracic part is going to be supplied by the aorta directly. The aorta has esophageal branches that are going to nourish the thoracic portion. Then the abdominal portion is going to be, of course, nourished by the left gastric. The left gastric, as you see here, is a branch of the celiac trunk. The celiac trunk, last time we said it has 3 branches. It has 3 branches. I don't know if someone can remind us. If you remember, you can raise your hand and speak to us. What are the 3 main branches of the celiac trunk? Yes, at Aston.
The 3 branches of the celiac trunk are the gastric artery, the splenic artery, and the hepatic artery.
Okay. Anyone to correct him somewhere? 3 branches of the celiac trunk.
We have 3 branches. We have the left gastric artery. We have the splenic artery going to the spleen. Then we have common hepatic artery.
Yes. So this this one going to the left side. This one here is the splenic. This one going to the right side is the common hepatic. This tiny one going upwards is the left gastric to supply the stomach, and it gives off branches that we call esophageal branches, supply the lower abdominal portion of the esophagus. Venous drainage, the cervical part is drained by the inferior thyroid vein, as you can see. Okay. Of course, all these veins are going to be collecting blood from the submucosal venous plexus. This is the plexus that's going to be draining blood from the esophagus, pouring it into different veins. In the cervical part, the submucosal venous plexus connects to the inferior thyroid vein, which is going to be taking away blood. Of course, this blood it will eventually reach the heart. Then the thoracic portion will be drained by, on the right side, by the azygous vein, on the left side by the hemiazygous and the accessory hemiazygous. Then the abdominal portion is going to be drained by the left gastric vein. The left gastric vein. This vein is going to, of course, come and connect to the hepatic portal vein. Okay. So the left gastric connects to the hepatic portal vein, as I mentioned. So, of course, this venous drainage is linked to very important clinical correlate, esophageal varices, and of course, esophageal varices, these are disease. There is liver disease, as we learned last time. Blood is going to be blocked from going through the liver. The blood channels in the liver can be blocked because of the probably inflammation of the liver tissues, blocking blood from going through the liver. That blood will come back into the portal vein, and from the portal vein, this blood will fill all the tributaries of the portal vein. Among the tributaries, we have the left gastric. Blood will come in the left gastric, and this blood will enter the anastomosis between the left gastric and the esophageal veins. These anastomosis are, if they are overfilled with blood, they can cause those small veins making up the anastomosis can enlarge, and of course, resulting into esophageal varices. These veins are going to be enlarged. They can be seen when you use an endoscope to look into the esophagus of this person. See those enlargements. Beneath it, there are enlarged veins. Those swollen areas beneath them, they are enlarged veins. Veins that can easily rupture upon swallowing, resulting into vomiting of blood, or what we call hematemesis. So hematemesis can be one of the complications of liver disease. GERD is gastroesophageal reflux disease. Normally, at the lower end of the esophagus, there is a sphincter that always closes to prevent gastric contents from leaking into the esophagus. This sphincter sometimes can be weakened if there is hyperacidity. There is excess acid in the stomach. The excess acid can be there because of many reasons. Simple reasons: if you overeat, there'll be excess acid in the stomach. Okay, you eat spiced foods, they can induce excess acid production in the stomach. That excess acid can come and weaken this sphincter, resulting into what? Reflux. Okay, so as the acids are going up into the stomach, there's going to be some bit of burning sensation in the chest because of the irritation of the esophagus. That can So that can be called a heartburn. Okay. This can also present in patients with peptic ulcer disease because in those patients there also be excess acid in the stomach. Okay, but even though you don't have ulcers, you can have this. It's normal to have it if you overeat, if you eat spiced foods, those carbonated drinks, if you... Also the sleeping posture. I want you to find out why. There is a particular sleeping posture that can easily, let's say you've eaten your supper, there's particular sleeping posture that can increase chances of these contents refluxing upwards. Which posture is that? Is it the right lateral recumbent posture or the left? Based on the orientation of the stomach, find out which position can increase chances of reflux when you're sleeping. Okay, so that is GERD. Of course, that GERD is not managed. Of course, it can cause inflammation of the esophageal wall to be severe, and ulcers can form in this wall of the esophagus. And also because of the chronic inflammation, strictures can form. Or as whenever an area is inflamed, the mucosa there is going to tighten, resulting to narrowing of the lumen of that part of the body. We call that a stricture. That's now a pathological narrowing. It's not the anatomical narrowing. The anatomical narrowings, we talked about them, those constrictions, but this is now pathological. It's coming in because of the inflammation. Okay. So you can start narrowing even here. Whenever there is a continuous reflux, the epithelium of the esophagus is going to be shed off, and it can be replaced with the epithelium of the stomach, as I mentioned. And as that happens, the Z line is going to shift upwards. Remember, this is the junction between the esophageal mucosa and the stomach mucosa. So as contents go upwards, we are going to see metaplasia setting in. What's metaplasia? What's metaplasia?
Metaplasia is a reversible adaptive change in which an adult cell type is replaced by another adult cell type.
Okay, so in metaplasia, there's going to be transformation of one cell type to another. So here we have this squamous, okay? Stratified squamous. Here we have the simple columnar epithelial cells. As reflux occurs continuously, this epithelium is going to replace the epithelium in the esophagus. Because naturally, this one in the stomach is adapted to the acids. It is used to the acid. So with time, it's going to replace the epithelium of the stomach because of the chronic reflux. That is intestinal metaplasia. We are calling it intestinal because the epithelium that is replacing the one of the esophagus is the usual epithelium that we see also in the intestines, the simple columna. That's why we are calling this intestinal metaplasia of the esophagus. Whenever it happens, it increases the chances of cancer to form in the wall of the esophagus. It can be seen on the endoscopy, but also this erosion can be seen. You see that that grayish erosion. That's because of the erosion of because of the chronic inflammation of the esophageal mucosa. So that is called Barrett esophagus, a complication of long-standing GERD. It can easily transform into cancer if it's not managed early. Achalasia, that's a narrowing of the lower part of the esophagus. Mostly this narrowing is going to be at the level of the lower esophagus sphincter. We say this sphincter usually it has to, of course, open up to allow contents to come in the stomach, then it has to close to prevent reflux. In a person with achalasia, this person is going to have a sphincter that is very tight. It's going to be very tight, it's going to be narrowed. Of course, this abnormality can occur because of the underdevelopment of the nervous tissue in this area of the lower esophagus sphincter. Normally, there should be nervous tissue that allows contraction and relaxation. In this case, there's going to be continuous tightening of this sphincter. And over time, it's going to result into enlargement of the proximal part of the esophagus because the contents cannot easily go through. And if you look at this, mimics the bird's beak. That's why I call this the bird beak is sign of bird beak's appearance. Because of that narrowing there, mimics the beak of a bird. Clinically, this patient is going to present with dysphagia, that is difficult in swallowing, pain on swallowing, okay, or sometimes there can be regurgitation of the undigested food substances. Okay, so that's what I summarized about the esophagus. Of course, without wasting time, we can shift and look at also the stomach. I decided to look at these all at once because they are very short. They're not detailed, easy to understand. You already know about them. I'm just adding a few things. Okay. So if you look at the stomach is, of course, in the abdominal cavity. And look at these 9 regions that we learned about last time. The stomach is going to be mostly in the epigastric region. Partly, it can extend into the left hypochondriac. Okay, that's the anatomical location of the stomach. This is a patient sleeping downwards in the spine position. That will be the approximate location of the stomach. The location can vary if this patient has just taken in food. Stomach can distend somehow to somehow come into the umbilical region slightly downwards. Okay. If this is a patient with a patient who is slender, tall, this patient is going to have a long abdomen, and it's possible for this stomach to also dip downwards into the umbilical region. The patient is short with a very large abdomen, not long and narrow but large. The stomach is going to be just concentrated in the epigastric region. So the someone's physique can determine the position of the stomach. Someone has just eaten, The stomach will also be downwards. Someone is having an empty stomach is going to be in the epigastric region. So there are different factors that can result into variation in the location of the stomach. You can read more about them. Factors that result into variation in the position of the stomach. So in a spine position, you can see the landmarks for the stomach. The stomach has parts, as we are going to learn, but you already know them. You have the cardia, that part next to the esophagus. This dome-shaped portion is the fundus. We have the body, then the pyloric region. So if you look at the cardia, this cardia is going to be situated at the level of the sixth costal cartilage. This is rib number 4, 5, 6, sixth costal cartilage, just alongside the xiphoid process. You can feel your xiphoid process, okay? Just on the left side a few inches, we have the cardia there. The fundus is going to extend up to the level of the fifth rib and its costal cartilage. Then of course the body is going to cross the midline towards the left side, and of course it terminates by becoming the pyloric region. This is the pyloric region. So these bony landmarks, at least you can remember them always, so that you can sometimes use them to locate the different parts of the stomach. Just below the fifth rib, we have the fundus. The level of the sixth rib and the costal cartilage, we have the cardia. Level of the seventh, eighth rib, we have the body, which crosses the midline towards the left side. Of course, here we have no any bony landmark that we can mention. Okay, so that's the surface anatomy of the stomach. You can describe its position using those landmarks, those skeletal landmarks. The parts, of course, as I mentioned, part 1 is the cardia, part 2 is the fundus, this dome-shaped portion. Central portion is the corpus, or the body. The whole of this is the pyloric region. And you can further see fundus, body, then pyloric region here. It's the cardia. So the fundus and the cardia are going to be separated by this angulated area. How is this one called? How do we call this? Where my cursor is? How do you call this anatomically? Where my cursor is? Anyone should tell us.
Cardia notch.
Okay, so that's the cardiac notch. Okay, and it can also be called the angle of His. So basically, it's that notch there in the cardia and the fundus. Fundus is dome-shaped, as I mentioned, area number 2, or part number 2. And this fundus, sometimes it can be filled with gas, because, of course, as the food contents enter, as you swallow, you may swallow, of course, you may take in some air as you're swallowing, but you know air is less dense. It's going to be trapped up here in the fundus, making the fundus to appear darker on X-ray because of the air or the gas bubbles that can be trapped within it. Okay. Then this is the body, of course, goes up the level of the this angular incision, which is going to be separating it from the pyloric region. The pyloric region is divided into two. We have this wider portion that we call the pyloric antrum, and this narrow portion is the pyloric canal that terminates at the orifice that we call the pyloric orifice, guarded by a valve. That valve there is the pyloric. You can call it a valve or a sphincter, the pyloric sphincter, that regulates exit of chyme from the stomach into the duodenum. Okay, so all that area number 4 is the pyloric region. This wider part is the antrum. This narrow part is the canal, guarded by that pyloric sphincter. Okay, so same thing here. We've mentioned about all the parts. The right margin of the stomach is called the lesser curvature. That right margin. The left margin is the greater curvature because it's going to be longer. Okay, mentioned about the cardiac notch, the angle of his, then the angular notch. Cardiac notch separates the cardia from the fundus. Angular notch, it's going to be demarcation between the body and the pyloric region, using that imaginary line there from the angular notch going downwards, demarcating the body from the pyloric region. Okay, look at the inside of the stomach. It's going to be folded. The mucosa is going to be highly folded, and we can call this gastric rugae. And of course, these foldings allows the stomach to later on expand. Let's say if you take a large, if you eat larger quantities of food, stomach can easily distend because of these folds. Can allow it to distend easily. Of course, the stomach has got same arrangement of layers, just like other parts of the GIT, though here in the stomach, the mucosa is highly modified. It's highly modified to form these longitudinal structures that we call the gastric glands. These are gastric glands. They are going to be made up of cells that will be producing different products, so that those products can come out into the lumen of the stomach via these tiny openings that we call gastric pits. Okay? So these glands, of course, are made up of cells. We have different cells, and those cells can be seen here. We have the chief cells that will be helping producing pepsinogen, parietal cells producing acids, HCl, to activate the pepsinogen to pepsin. The acid can also help in killing some bacteria that may have come along with food. The acid also creates good environment for allowing the pepsin to function normally. That acidity is good for pepsin. There are many other cells. There are very many other cells. Very many other cells that make up the gastric glands. You can read about them. For each cell, you have to appreciate the product produced and the relevance of that product. There are very many enteroendocrine cells producing particular hormones that will be part of gastric juice. The layers, as we just said, the same layers like the other layers of the GIT. Outer one is the serosa. Okay. For the esophagus, the outer one was the Adventitia. We say the Adventitia is highly modified to allow structural support of the esophagus. From the stomach downwards, the outer layer is the serosa. The serosa is also modified to allow lubrication of these organs so that they are not easily injured when they collide against the abdominal wall. So basically the outer layer is just for protection. We have the muscle layer, what I call the Muscularis propria. It's the same thing. It's going to be, of course, a layer that will allow peristalsis to occur, to allow chyme to be pushed from the stomach towards the duodenum. Okay? Since there are many content, there's going to be an increased volume of contents in the stomach. We need more muscle fibers to push these contents via this tiny opening at the pyloric canal. That's why within your stomach wall, we not only have the circular muscle fibers, we not only have the longitudinal muscle fibers, but you also have the oblique muscle fibers to allow the stomach to forcefully contract, to allow expulsion of all of its contents via that tiny opening, the pyloric canal, via the pyloric sphincter, to allow the contents coming into the duodenum. Then, of course, we have the submucosa, then the mucosa. These layers, of course, you can also see them here. This picture is basically showing them in different colors based on how this it's in a bright color. In ultrasound, we use the term that we call hyperechoic. It's bright. Hyperechoic means bright. Then the muscle layer, it's darker, hypoechoic, probably because of the coarse muscle fibers there. They are going to be condensed and they are going to make this layer appear darker. This also just has connective tissue and some epithelium that may just make it appear brighter. Then beneath the muscle layer, we have the submucosa that also has connective tissue and some blood vessels, making it appear brighter. Now, as we go deep, we are going to see the mucosa. This mucosa is the mucosa is divided into two. The mucosa, if you look at it here again, this is the mucosa, right? You can see it's going to have different appearances. Look at the lamina propria, this connective tissue here, the lamina propria containing the glands will not appear the same way like this thin muscle layer of the mucosa, the thin muscle layer that we call the Muscularis mucosae. Of course, since it contains muscle fiber, it's going to appear more darker than this other section of the mucosa. That is why in this image, the mucosa, we are dividing it into two. Okay, there is that part of the mucosa that contains Muscularis mucosae, that thin layer of muscle fibers. Then there's that inside part of the what? Of the mucosa, just made up of the lamina propria and epithelium. It's going to be hyperechoic. Then the muscular zone of the mucosa is going to be hypoechoic because of the muscle fibers within. So in general, we know the layers of the stomach, they have to be from the outside layer, we have the serosa. As we go deep, we have the muscle layer. As we go deep, we have the submucosa. Then we have the mucosa. But this mucosa, I have just said, we are dividing it into two, okay, because of the differences in the appearances of its contents. There is part of it that appears darker. That's the part containing the thin muscle fibers, the Muscularis mucosae fibers. Then there's part of it that appears brighter, that part containing connective tissue and the epithelium. It's going to be appearing brighter, and it's what you are seeing here. This is appearing darker because of the muscle fibers that are contained within it. That this muscle layer here makes it appear hypoechoic. Then the rest of the mucosa is hyperechoic. Of course, beneath the mucosa, we have the space or the lumen for the passage of the contents. So same explanation, serosa is brighter. As you go deep, you have the muscle layer. As you go deep, you have a bright submucosal layer. As you go deep, you have, of course, now the mucosa, the outer zone that contains the Muscularis mucosae, this zone here, okay, contains the Muscularis mucosae and of course the parts of the glands. Then the next brighter layer is the layer that is going to be containing more of the epithelium, and it's going to be next to the lumen, as you can see. So those are the layers of the stomach. It's the same appearance, the same appearance of layers. Even when you look at the small intestines, there are just a few changes, a few differences. This is your stomach, an ultrasound. Of course, this is the abdominal wall. You have the liver here. You have the stomach here in cross section. And look at the layers. You can further see them here. Serosa is that outer layer, bright layer. You have this thick muscle layer. The submucosa, you can see it there, bright. Then the muscularis, then this inner brighter layer is that layer of the mucosa containing the epithelium. You can call it the superficial mucosa, and this you can call it the deep mucosa containing the muscularis mucosae. Then after this thin layer of mucosa, which is brighter, as you go deeper, you of course land into the lumen, that space containing the contents. Okay, so that's arrangement of the layers. If you look at the relations of the stomach, of course you have structures in front of it. Obviously, the anterior abdominal wall. Of course, you can see part of the diaphragm coming over it. Of course, the left costal margin, you see the left costal margin there, over it. The left liver lobe, here it's reflected, but here you can still see it in situ over the stomach. So those are the structures in front of it. Of course, then behind it, of course, in this transparent image, you can see the pancreas behind it. You can see what else? You can see the, of course, part of the diaphragm. This is the diaphragm. If you look on the inside aspect, there are some muscle fibers of the diaphragm coming downwards. They're posterior to the stomach. The spleen, this left adrenal, you can see the splenic vein, the splenic artery over the pancreas. Okay. What else? You can see some vessels that are going to the diaphragm. This is the inferior phrenic artery going to the diaphragm. The upper part of the left kidney, this is your left kidney here. The upper part, you may not see it well, but it's there. And just over it, we have that gland, the left adrenal gland. Okay, so all those structures are posterior to the stomach, but they are separated from the stomach by the lesser sac. The lesser sac, if you remember in our discussion last time, it is that it's part of the peritoneal cavity, and it's going to be situated posterior to the stomach, or you can say between the stomach and the pancreas. That space, you can enter through it via this epiploic foramen underneath the lesser omentum. That space all the way posterior to the stomach, it's the lesser sac. So between it between the lesser sac and between the lesser sac, or between the stomach and the pancreas, we have the lesser sac, to be exact. So it goes posteriorly to reach the posterior aspect of the stomach, separating the stomach from the lesser from the pancreas. Okay? So those are the structures posterior to the stomach. They form the stomach bed. They are going to form the stomach bed because that's where the stomach is going to be lying. So of course you can still see them, the pancreas, the left adrenal, part of the left kidney there. You can see part of the transverse colon and its mesocolon. You can see the celiac trunk, part of the spleen. Okay, all those structures, they form the stomach bed, but they are separated from the stomach by the lesser sac, which is space around here. Okay, so those are the what? The relations of the stomach. Of course, this stomach can be well appreciated on ultrasound, and those landmarks, the vessels nearby it can be seen, the structures close to it can be seen. It can be scanned in many ways, and this is an ultrasound scanner or probe or transducer. Here it's oriented in the vertical plane or in the sagittal plane. We are going to be scanning in a sagittal manner. You can scan in different angles, okay? But all in all, if you position your transducer in such a way, vertical oriented, in the epigastrium, you can see that plane is going to be slicing part of the stomach, the antrum specifically, okay? And of course you see part of the liver and these other parts. Let us try to visualize what we can see. So in the sagittal plane, that plane is going to be intersecting the antrum, and you'll be seeing here the antrum very well. This is a sagittal view of these abdominal structures when you place your probe in such a vertical orientation. Just to make it easier for you, on the ultrasound image, the structures seen this side, they are cephalad, they are superiorly oriented, they are towards the head. Then structures on this left side of the image, they are caudally oriented, or they are the inferior structures. Okay, remember the patient is lying downwards. The probe is placed in the vertical plane. Okay, the probe mark is facing the patient's head. Patient's head is towards that side where the probe mark is. So these are superior structures, these are inferior structures. Okay, this is the skin of the patient. So we have the anterior most structures here, the posterior most structures are this side. So if this is the skin, of course this is the abdominal wall. The abdominal wall. If that's the abdominal wall, of course we have the liver. We said part of it is going to be lying over the stomach. Part of the liver, the left lobe, is going to be lying over the stomach. So you can see the liver there, just part of it. You can't see the whole of it because you can't, the plane you're using is just slicing part of it. You can't see the entire liver, just seeing part of it. And it's anterior to the stomach. And specifically, the part of the stomach that we are seeing here is the antrum. Remember, the antrum is in the midline. The antrum of the stomach is in the what? The midline. This is the antrum of the stomach, or the pyloric antrum. It's in the midline. It's part of the pyloric region, remember. So it's in the midline, that's why it's the portion that we are seeing. And of course, posterior to it, we have the pancreas. You can see the pancreas there. Yes, we know the pancreas is posterior to the stomach, and it's what we are seeing here. The pancreas is closely associated with this vessel superior mesenteric artery. This vessel comes from where? Comes from the aorta. This is your aorta, close to the vertebral column, okay? And though you can't see this vessel coming from it, but it comes from it. It's arising from the aorta and close to the pancreas, and you can see it here, arising from the abdominal aorta. Remember, we are scanning in the vertical plane. Remember also the aorta is vertically oriented. That's why you can see the whole length. Not the entire aorta, but at least you can see this longitudinal orientation of the aorta, because we are in the longitudinal plane. And the aorta we know is in that plane, going downward. Okay? Going downward. This is downwards. That's the aorta. And of course, posterior to it, of course, we've said we have the vertebral column. And you know, bones appear darker. Bones appear dark on ultrasound. So can't easily name the different vertebral bodies or vertebra, but you can imagine this to be our spine. It's going to have, the bones appear darker. That's why you can't easily distinguish the different vertebra. Okay, so that is our antrum, and those are the relations. So the abdominal is anterior, the part of the liver is anterior, the pancreas is posterior. At least we can see that. Okay, so we shall be coming back to these images later to talk about something. The blood supply. The blood supply is very easy to understand. And if you remember, the stomach is derived from the foregut. This was your foregut, giving rise to the pharynx, to the esophagus, now to the stomach. And most of the structures of the foregut are going to be supplied by the artery of the foregut, which is the celiac trunk. It's the artery of the foregut supplying all these structures. So it's going to be dividing into many branches. For example, of course, we have the left gastric, that one there, coming to supply the lesser curvature. Okay. Then you have the splenic there, running over the pancreas, posterior to the stomach. It's going to come and travel towards the spleen, but before it reaches the spleen, it has branches that we call short gastric arteries, about 4 to 5, supplying the fundus. And after reaching next to the spleen, it's going to give rise to the left gastroepiploic, or you can call it the left gastro-omental artery, coming to supply the greater curvature. Okay. This greater curvature is not only supplied by the left gastric, it is supplemented by the right. It's not only supplied by the left gastroepiploic, it's supplemented by the right gastroepiploic. But the right gastroepiploic is from the gastroduodenal. Remember, the gastroduodenal is a branch of the common hepatic. This is the common hepatic, giving off the gastroduodenal giving off the right gastroepiploic to come and anastomose with the left gastroepiploic to allow supply of the greater curvature. Then this common hepatic, after giving off the gastroduodenal, becomes the hepatic artery proper, an artery that is destined to go to the liver. But before, of course, reaching the liver, it's going to give off a small branch that we call the right gastric artery. It's coming towards the lesser curvature to anastomose with the left gastric artery so that the lesser curvature can be well supplied with blood. So we have this anastomosis intended to allow continuous supply of blood to the wall of the stomach, even though there is an obstruction in any. Let's say if there's an obstruction in this, the right gastric can still bring blood to the area that has to be supplied. So that is the blood supply. Of course, the stomach, just like any other part of the body, has to be nourished for proper functioning. Okay? We have muscles that are going to be actively working. We have glands that have to produce gastric juice. Contents of the gastric juice, most of them are going to be delivered by this blood coming in. Okay. So, same thing here. I won't repeat, but I've talked about all these branches. Okay, so among the abnormalities that can occur, I don't know why you're taking us back to the esophagus, but among the abnormalities of the esophagus that can occur, agenesis is rare. Agenesis is rare because during development, the gut tube has to form. By all means, it has to form. And this tube is contributing to the esophagus. So cases of agenesis I've never seen, and they're not reported in clinically. I've not seen any cases of agenesis. So if it is not there, just saying if the esophagus it is not there, it's just a pathway, remember. It's just a what? It's just a pathway. Let's say it's not there. It's possible to connect the pharynx to the stomach. Surgically, there are tools, there are different artificial products that can be used to, of course, create a path. A path has to be created. But as I said, cases of agenesis are rare. So it's possible for someone to live without the stomach. As I said, this is a digestive tract. It's a pathway for food. If the stomach is not there, the remaining parts can be interconnected to create a path. But as you know, the stomach is very important in many functions in the body. There will be, of course, very many outcomes of that surgery. If there is need to remove the entire stomach, the person can live, but there are very many complications that can set in because this stomach doesn't only produce enzymes for digestion, it helps in producing some chemicals that allow absorption of vitamins. So without that, this person can develop anemia. This stomach is very, very important in many ways. So, of course, there may be some bit of complication, but this person can survive. The person can survive. Venous drainage. Venous drainage, of course, shows us veins that drain the stomach. We have the short gastric veins draining the fundus, pouring into the splenic. We have the left gastromental draining the greater curvature, pouring into the splenic. We have the right gastric draining the lesser curvature, pouring into the portal vein. Left gastric also draining the same area, pouring into the portal vein. Okay. We have the right gastromental draining the wall of the greater curvature and later draining into the superior mesenteric vein. The posterior wall of the stomach drained by the small veins, these small veins here that are supposed to later empty into the splenic. This is your splenic. Receive some veins from the posterior wall of the stomach. And of course, as you already know, it's going to be joined by the inferior mesenteric, then later to join with the superior mesenteric to form the hepatic portal vein. So the veins draining the stomach are easy to understand. Peptic ulcer disease, I've somehow talked about this already.
The left gastromendo vein and the right gastromendo vein, do they anastomose or they just live like that?
Yes, they join and they are going to help each other. Remember, this is the greater curvature. It's a very big surface area for the stomach. So these two veins join and they all contribute to the drainage of the greater curvature of the stomach.
Okay.
Yes. So, as I was saying, peptic ulcer disease, I partly talked about it already. Ulcers are wounds, as you know, wounds that can be in the stomach and in the duodenum. And these wounds are going to be mostly along the lesser curvature because it's a pathway. It's going to be a common pathway for food substances. And so this lesser curvature is almost in line with the esophagus. So contents are just going to be sliding, rolling downwards along the lesser curvature. So making it an area mostly associated with these ulcers. Then the antrum also, and also since the duodenum is nearby, it can also be affected, mostly the first part. What can cause these wounds? And could be many things. Could be this bacteria, could be overuse of NSAIDs like aspirins, diclofenac, those painkillers. Overuse them, they reduce the rate of mucus production in the stomach, making the walls prone to injury by the acid produced in the stomach. Too much intake of alcohol, too much smoking, overuse of these steroids, all these may just make the ulcers worse. Symptoms, of course, epigastric burning, or you can say dull, painful sensation around the epigastrium, changes in appetite, all these are symptoms. Complications, a wound can go through the wall to poke a hole in the wall of the stomach. That is called perforation. Of course, it will lead to internal bleeding. And these wounds, sometimes they can become cancerous. So that is peptic ulcer disease. Of course, it can be seen by an endoscope. An endoscope can clearly help in visualization of these lesions. They can be well seen. But of course, this is number one and a very expensive procedure. And sometimes if a patient can't tolerate it, because of it being invasive, ultrasound can be carried out. On ultrasound, the ulcerative areas can be seen. On endoscopy, this is how the ulcer is going to be seen. That's a wound somewhere there. And around it there is inflammation causing that redness that you see. So that's a wound that you see, but also you can see it here in the wall of the stomach. So ulcers can not only be seen on endoscopy, but also on ultrasound, those wounds can be seen. Okay, you can see in the wall there is some bit of fluid because of the inflammation, the same inflammation that you see here. Okay, then there is what we call hypertrophic pyloric stenosis. This is just from the name itself. Stenosis means narrowing of the pyloric canal because of increased thickness of the pyloric region. The pyloric region, of course, we know that's the terminal end of the stomach, And we say it's divided into the antrum and the canal. The canal is going to be lined by sphincter that we call the pyrrhic sphincter. This sphincter is just made up of circular muscle fibers, fibers that can sometimes abnormally hypertrophy, they can increase in size, making this pyrrhic canal to be thickened. Okay. Then also the passageway for the contents is going to be narrowed. Of course, because of that, any food content taken in will just be vomited. Okay. Remember, there is a very narrow gap there, so contents are going to accumulate here and they are going to be projected with a greater force. And we call that projectile vomiting. It's non-bilious because it doesn't contain biliary or bile contents. But bile is produced by the liver, stored by the gallbladder, poured into ducts that are going to be joining the small intestine. So the obstruction is before the small intestine. So that's why I say that the vomitus is going to be non-bilious. It's not going to be greenish because it doesn't contain bile. Of course, this will result into swelling of this part of the stomach, resulting into that rounded, centralized swelling on the abdomen of these babies. And we call this an olive-shaped mass. It's in the epigastrium. Just by seeing that, and also seeing this projectile vomiting, automatically just know this baby has got hypertrophic pyrrolic stenosis. This stenosis can be appreciated in ultrasound. Of course, you know, we said in this wall of the pyrrhus, we have, of course, muscle, and these muscles can thicken. If they thicken, that thickness can be appreciated in ultrasound. It's the liver, we have the stomach here, and of course, this thickness can be well visualized. Okay, the muscles are greatly thickened. Of course, the layers of the stomach can still be seen here. We have the serosa, the outer layer. This is the muscle layer. This is the muscle layer on this side, muscle layer on this side. The lumen is very narrow. It's very narrow because of the thickness of the muscle layer. This thickness is not supposed to be greater than 3 millimeters in the measurement or in the diameter. But if it's more than this, that means there's a problem. There's something abnormal. There is wet thickness, and that can be seen on ultrasound. This was a longitudinal image, and you can also see the thickness in a circular or in a cross section, as you can see here. It's a cross section of the pyrrolic or the pyrrolus, also showing us the great wall thickness, and the diameter. The diameter is going to be really increased because of the wall thickness. The diameter is not supposed to go beyond 14 millimeters. It goes beyond 14 millimeters, this diameter here, that means there may be a problem. And here the problem is obvious because you can see the muscular wall thickened. Okay, so you can easily diagnose this on ultrasound. The passage of contents is going to be very narrowed, very, very narrowed. And that's why it creates a resemblance of the cervix. You know the uterus has got the lower part that you call the cervix. There's a tiny gap. And this representation is going to be similar to this representation. That's why this sign can be called the cervix sign. So the pyrrhus is mimicking the resemblance of the cervix. You can see the wall and with a very narrow channel, something resembling the cervix. It's not the cervix, just a sonographic sign. The thickness of the muscle wall is going to also resemble the so-called target. You know these targets that are used in darts? So that's the target sign, and because of the thickness of those concentric muscle layers that make up the pylorus. Okay, so that's the target sign. All these sonographic features appreciate hypertrophic pyloric stenosis. Finally, as we finish, the stomach can also be scanned. For example, in patients that are scheduled for surgeries. Why? Because always someone is going into a surgery and this person's stomach is full. That is a very great risk of aspiration. It can increase chances of aspiration to occur. In aspiration, contents can easily move upwards, going into the airways, resulting into severe respiratory complications. And most of the deaths most of the fatalities that occur in people scheduled for surgeries, those fatalities occur because of this pulmonary aspiration that occur, if at all the stomach is not empty. So always in such patients that are going to be numbed or that are going to be undergoing general anesthesia, those patients have to be scanned. Okay? Because these drugs that are used, they can easily cause relaxation of this sphincter, increasing chances of reflux to happen. So when can you do this? Of course, if your patient is the pediatric, you can't ask a pediatric whether this person has eaten or not. This is a young one. Of course, the parent can answer this, but to be sure, you have to scan the baby before the baby is scheduled for surgery. Of course, if there is any form of language barrier, and you can't ascertain whether this person's stomach is full or not, there is any altered mental status, the person is not mentally stable, the person is unconscious, can't really tell you whether they just eaten or they spend time without eating. If there is any underlying diseases, for example, diabetes. Diabetes can affect the gastric emptying. Okay? Gastric emptying, that's when contents leave the stomach from the stomach to go to the duodenum. So patients with diabetes, patients with neuromuscular diseases, all these patients can have delayed gastric emptying. So these patients, contents take long to leave the stomach. That's why, of course, they have to be scanned to really ascertain whether it's empty. Okay. In ultrasound, there's part of the stomach that's going to be scanned is the antrum. This antrum can give clear indication of whether the stomach is full or not. Scanning can be done when the patient is lying in the spine position or when the patient is lying in the right lateral decubitus or right lateral recumbent position. Or these are ways how you can scan the antrum. Remember, the antrum is in the midline, so you can position your probe in the midline in such a way, appreciate the antrum in sagittal, or in such a way, also appreciate in sagittal, but when the patient is lying on the right side. Why the right side? The right side is preferred because, of course, if there is any content here, this content will come and settle into the antrum. and it can be seen. Okay, it can be seen clearly. When the patient is in the right lateral decubitus position. Okay, so just a few images to see the stomach in different cases. Let's say the stomach is empty. Of course, again, remember, this is towards the head of the patient, towards the feet of the patient. This is anterior, this is posterior, this is skin, abdominal wall. Then, of course, we have the liver, okay, close to the stomach. This is just the antrum that you're seeing. It's very small because it's empty, nearly flattened, nearly collapsed, and nearly round because it is empty. So if it's empty, that's how it's going to appear, like a bull's eye appearance. So you can see it's round, flat, or collapsed. When the patient has, for example, spent time without eating. If the patient has just taken in food, those solid food particles, they are going to be feeding the antrum. And you know these solidified contents, they may not allow this ultrasound waves to go through. That's why posterior to the antrum, you just see shadow because these waves are going to be obstructed from going through. So you can't see anything posterior to the antrum. You just see a shadow. That means there are solid contents in the antrum. Okay? So this is someone who has just eaten like a few hours ago. Of course, after some time, after eating, of course, the contents are going to be, of course, there's going to be digestion going on to form the chyme. And after like several hours after eating, this patient is scanned, you just see a heterogeneous mixture of contents. This is chyme in the what? In the stomach. It's a late stage, like after many hours eating. Let's say after like 5 hours or 6 hours. Okay, this can be an appearance like after a few minutes or 1 hour after eating. After several hours, contents are going to be, of course, being worked on, and just a mixture of contents in the stomach. Okay. Then if a patient has just taken in fluid contents, drinks, any drink, you just see, of course, you can see this fluid in the antrum. It really appears darker in ultrasound. So the antrum is distended, as you can see, with the fluid inside it. So it's very important to ascertain whether the antrum is empty or full so that this patient does not suffer from the aspiration that can occur when he or she has been knocked out. The general anesthesia can knock out this patient, and if there is any contents in the stomach, there is a very high risk of aspiration. If the contents are seen before surgery, they can be removed. They can be sucked out by the tube, the orogastric tube, for example, so that during the surgeries there is no any risk of what? Aspiration. So that's another reason as to why the stomach has to be scanned. There are many reasons to find different pathological conditions, ulcers, and others, but also to ascertain whether it's empty or full in patients that are scheduled for surgeries.
Basically, with aspiration, it means that, remember, when food is entering, in this path, you're finding that food is again entering the trachea instead of moving down, entering into the esophagus. And that is not the right path through which food should take. So, and that is sulfate. So that is what we call aspiration.
Okay, so aspiration The word itself can mean to breathe in, okay? We know that we are supposed to breathe in air normally, but in this case, you are going to be taking in contents into the airway, contents that are not supposed to be there. For example, the stomach contents. The stomach contents are going to be pushed upwards through the esophagus, from the esophagus into your throat or the pharynx, and from the pharynx, there is that laryngeal inlet that has to be closed by the epiglottis. So contents can pass there and leak into the airway. In other words, you'll be inhaling in gastric contents. That is the aspiration that we're talking about, or you can call it pulmonary aspiration. Said, that is possible because in this state, the patient has been injected with anesthetic drugs that can have different side effects, leading to that abnormal aspiration of contents upwards. So to prevent that, contents are not supposed to be there. If they are there, they can be removed before the surgery. Chapters they have to talk about: number 1, swallowing reflex, gastric and pancreatic juice circulation and regulation. Yes, all that it has to be talked about, but I decided to first talk about the esophagus, the stomach, before they come in to talk about those different physiological mechanisms. Okay? So, in our next session, I'll look at the hepatobiliary system. Then after that, I cover the pancreas and the spleen. In our next session, I'll be covering the hepatobiliary system. Then after that, we look at pancreas and spleen.
My question is on ulcer. Now, there are many scenarios that patients comes to you with typical signs, symptoms of ulcers. But if you sometimes run the antigen test, you'll find that they are negative. Now, my question is, are there types of ulcers that if you run the tests with that antigen test kit, then it will show positive? That is my question.
I beg your pardon, your question?
Now, the question is, there are some patients that they may come to you in the facility with typical signs of having ulcers. But now, if you run the test, because there are places that do not have scans and the rest, but now, if you run those tests, like the antigen test, you'll find that the results are negative, and yet there are many or typical signs of ulcer. So, are there types or maybe causes of ulcers that if you run those tests, it will turn positive?
Okay, so as I explained, there are very many causes of ulcers. Okay? First of all, those antigen tests, what are they intended to detect? Alex, what are they intended to detect specifically? Alex?
I just think they're intended to detect antibodies produced against some microbes. That is what I think.
Yes, they're supposed to detect antibodies produced in this patient's blood. Antibodies produced as a result of antigens released by a germ called Helicobacter pylori. So if this patient has got ulcers, because of Helicobacter pylori, obviously, this antigen test will be positive. It will be positive, okay? That is the blood test, the antigen test. Sometimes stool, feces can be examined to check directly for the antigens produced by these germs in the fecal, in the stool sample, okay? All those tests are intended to check if this person has got this Helicobacter pylori. But there are other causes of ulcers. For example, I said NSAIDs, the non-steroidal anti-inflammatory drugs, they can cause ulcers, okay? So if someone has got ulcers and the test is negative, probably this patient has got ulcers because of other factors. For example, probably chronic intake or overtake of those NSAIDs, those drugs, those painkillers, the diclofenac, the aspirin, and the rest. So, always when the test is negative, yet the patient has got symptoms, always you have to further get the patient history, ascertain the probable cause of these ulcers. There are many other causes, not only H. pylori. That's why it's possible for the test to be negative, yet the patient has got signs and symptoms of ulcers. That means that there are other causes.
There are some cases when one is vomiting, you find some vomiters has come through the mouth and others has come through the nose. Why is it always like that? Then another, always like that. When one is vomiting, there are times some vomiters come through the mouth and others via the nose.
Okay.
Then this is the second one is kind of a scenario. Assume I've done my ultrasound investigation. I found my patient has splenomegaly, liver metastasis, ascites, uterine metastasis, arthritis. You can see those are very many cases or conditions. How can they be managed? Like what should I start with so that you can get that person improve?
So, when a patient has what? I beg your pardon?
I've done my ultrasound examination. I found that my patient has enlarged spleen, has liver metastasis, and ascites, uterine metastasis, arthritis. You can see those are very many conditions on just one patient. I'm like, how can we manage that person? What should we start with? What should be coming first and coming last?
You know your anatomy very well. The patient has splenomegaly, ascites, and you've just said the patient has liver metastasis. That means this patient has got cancer arising from a certain part of the body, causing injuries in the liver, leading to splenomegaly and ascites. So you have to find out where this cancer came from. You've just said the patient has metastasis in the liver. That means cancer came from somewhere. So you just have to do a thorough check to confirm where this cancer is coming from. Or if you're in a good facility, of course, a liver biopsy can be done to examine the liver to ascertain which type of cancer is infiltrating into the liver. You can find that cancer, it can be managed, and these other symptoms can be also controlled. If that cancer has not spread severely in the body, it can be managed.
It was about vomiting. There are some cases when one is vomiting, you find some vomiters has come through the mouth and the other is through the nose. Why is it like that?
Now, you know what happens when someone is vomiting. The contents are going to be rushing towards the throat. You know the throat or the pharynx has got two exits, or let me say entrances. There is an entrance to the nose, an entrance to the mouth. So if the vomit is rushing upwards with a greater force, like in cases of severe GERD, It's possible for the contents to come out of the mouth, but also out of the nose. If there is severe cases of gastroesophageal reflux disease, for example. So from your anatomy, you can easily explain that. The throat has two exits. If the vomitus is coming in with a very greater force, it can come out of the mouth, but also come out of the nose. It's possible.